So our next speaker is Dr. Rahimi, who will be talking on endovascular management of carotid and vertebral stenosis.
Good morning. As Dr. Eid mentioned, there are multiple studies done in 1980s and 1990s to look into medical management with aspirin versus carotid endarterectomy and benefit of them. On the right side of the presentation, you see on the asymptomatic in 5 years the stroke risk reduction from 11% to 5%, aspirin versus CEA. Multiple study done for the symptomatic patient in 2 years, stroke risk reduction in NASAD North American study was 17% reduction. Also in European study, same behavior was observed. This slide just tells you the exclusion study was the same other than the symptomatic patient. Asymptomatic patient was excluded and vice versa in the ACAS study. The big question is medication, surgery, or endovascular intervention. And this is basically what I will cover. Not cover the technique, but I will cover the evidence available. Advantage of carotid stenting, if the patient has a contraindication for CEA, they have a high risk factor, cardiac risk factors. There would be no incision, obviously, for carotid stenting other than the access site. Depending if you use a TCAR, it might be a little bit of an incision. Avoids risk of cranial nerve injury and risk of adverse cardiac events. Safari study was published in New England Journal of Medicine in 2004, which indicated carotid artery stenting is not inferior to carotid endarterectomy. And this was a study that opened up and approved the carotid stenting in the United States, but it was funded by industry. One of the risks of carotid intervention with endovascular technique is stroke when you deflate the balloon, if you need to use a balloon, and when you deploy the stent. There are multiple embolic protection devices. In the middle, you can see distal filtration, which most often use the picture middle on the right. Or you could use balloon occlusion proximal and distally with reversal of the flow. So there are multiple embolic protection devices are available for you. One of the adverse anatomical criteria is the type of the aortic arch you have if you are going transfemoral access. And if you can imagine in the type 3, which is the picture on the right, it's very difficult to go up, down, again up to treat the right carotid. It would be very challenging, and most people will not do a carotid intervention with an endovascular technique for this challenging aortic arch anatomy. The 2016, Dr. Moore looked at the studies done before, and the size of the carotid lesion, the length if less than 13 millimeter, indicated a good outcome with the carotid stenting. But if lesion is calcified ulcer or free-floating thrombus, avoid carotid endovascular technique for these patients. If they have a adverse, they have the challenging anatomy with the aortic arch type 3, one of the techniques that can be used is a TCAR. In 2015 JVS Roadster trial, they used 208 asymptomatic and symptomatic patient, and TCAR indicated to be safe and effective at preventing a stroke during carotid artery stenting. They basically make a small incision here and also access a femoral vein and reverse the flow, so they don't have to go through the arch at all. The type of a stent, self-expanding stent, is preferable, closed cell, and taper versus non-taper. Some evidence has shown in 2009 and also vascular surgery that taper have a lower restenosis risk. And you usually measure the common carotid in order to find out what type of what size you need for carotid stenting. Again, multiple trials has been done and published in New England Journal of Medicine. In 2006, EVA, early trial termination because a 30-day stroke and death was significantly higher in carotid artery stenting, about 10%, versus carotid endarterectomy was 4%. In the SPACE trial, it failed to show any difference between carotid artery stenting versus carotid endarterectomy, and in ICSS 2010, in 120-day, a stroke and death MI was a significant difference between 8.5% in carotid artery stenting versus 5.2% in the carotid endarterectomy. These are all on the symptomatic patients. The CREST trial in 2010 that was published, they looked at the endpoints of, again, a stroke, MI, and death. There was no difference for symptomatic patient, carotid stenting versus carotid endarterectomy, but they saw increased risk for carotid artery stenting for age of 75 or higher. What are the recommendations? Class 1 recommendation: if the patient is symptomatic and have ultrasound finding of more than 70% of stenosis, the anticipated pre-op stroke mortality is less than 6% and indicated to do carotid endarterectomy. But if they have higher risk cardiovascular, redo carotid endarterectomy, or if they have a radiation field, carotid artery stenting is safe and has a less than 6% stroke and mortality rate. Class 2 recommendation for CEA is reasonable for asymptomatic patient, but in Europe most people are shying away to do asymptomatic patient, and hopefully CREST 2 trial will answer some of this question. And CES over the carotid artery stenting for older patient, again as the CREST 1 trial showed, and carotid artery stenting over CEA for patient with an unfavorable surgical anatomy is indicated. Medical management is crucial. What you need to know is aspirin, blood pressure, and statin is important drugs to make sure the patient is on if they're asymptomatic or symptomatic. For blood pressure control, ACE inhibitor first for patient with diabetic mellitus CHF. The calcium channel blocker highly effective blood pressure control, but less proven to reduce the risk of a stroke. And the target goal, the ideal goal is 120 over 80, but start treating if they have a 140 over 90 or higher. It's important to control your patient's blood pressure before any intervention to reduce the hyperperfusion syndrome post-sub-day 3. Statin, again, it's a very important drug. Increased evidence of benefit of using a statin for patients, and target triglycerol is less than 200. What we learn in medical school, LDL less than 70 is changing the ATP trial that you learn. And right now, most primary care physicians, they looked at the cardiovascular risk factor, LDL, more than 190, and if they have diabetic mellitus, and if they have the age more than 40, but less than 75. So the criteria is kind of changing. And the side effect of the statin that you should know, and you have to make sure the primary care physician follow up, is the leg cramping, myositis, and liver function panel test. Using aspirin, the low dose, again, as Dr. Ait said, is very crucial for your symptomatic and asymptomatic patient. Anticoagulation, no benefit has been shown. Again, the question is, to just summarize, what should you offer your patients? If the patient is symptomatic with a more than 70% stenosis on the ultrasound, and they have a high cardiac risk, CHF, ejection fraction less than 30%, recent MI, unstable angina, or previous CEA or radiation field, offering carotid artery stenting and knowing their anatomy and knowing their lesion length probably would be beneficial to offer the patient with carotid artery stenting. That's basically it. This is just a summary at the end of my presentation. Any question? Okay, thank you so much.